In our previous modules, we established the patient's identity in Section 1 and documented the specifics of the traumatic event in Section 2. Now we follow the patient's journey forward in time. Welcome to Module 2, Lesson 3, where we will focus on Section 3, Out-of-Hospital Care. This section is dedicated to documenting the critical pre-hospital phase of the patient's journey. Let us begin by outlining our learning objectives for this module. Upon completion of this session, you will be able to: first, identify the pre-hospital care or PHC form as the primary source document for this entire section. Second, define the principles of high-quality data entry as they specifically apply to pre-hospital data. Third, you will be able to accurately enter all fields within Section 3, which includes transport details, crucial timestamps, on-scene vital signs, and any interventions performed. Fourth, you will learn to correlate these pre-hospital data points to the structure and process components of the Donabedian model. And finally, you will be able to justify the need for meticulous accuracy when documenting this pre-hospital phase of care. Section 3, Out-of-Hospital Care. This section documents the patient's journey from the moment emergency medical services are engaged until the patient arrives at the hospital. This phase, often referred to as the pre-hospital phase, is a critical component of the trauma care continuum. The data you enter here provides a baseline of the patient's condition and a measure of our emergency response system's efficiency. We will proceed field by field to ensure you can transcribe this vital information with complete accuracy. The Out-of-Hospital Care section provides a unique and irreplaceable snapshot of the initial trauma response. This data is fundamental for several reasons. First, for evaluating system performance. The timestamps, from the moment a call is received to the patient's arrival at the hospital, are critical key performance indicators, or KPIs. They allow us to measure and improve the efficiency of our National Emergency Response System. Second, for establishing a clinical baseline. The on-scene vital signs and GCS represent the patient's true physiological condition immediately following the injury. This baseline is essential for researchers to accurately assess the impact of subsequent in-hospital treatments. And third, for auditing triage and treatment protocols. This data allows us to analyze the accuracy of field triage using the major trauma criteria and to evaluate the appropriateness of pre-hospital interventions. This in turn leads to improved clinical guidelines and training for our paramedics. Let's begin with Part 1, Transport and Timestamps. For field number 1, Transportation Method and Transfer Mode, you will select the options based on the ambulance crew's report. Primary response indicates the patient was brought from the scene of the incident, whereas interfacility transfer means they were brought from another healthcare facility. Your primary and indeed only source document for all of Section 3 is the Pre-Hospital Care, or PHC form. The PEARL, or best practice here, is to recognize that the timestamps are the most critical data points in this part. They must be transcribed exactly as they appear on the PHC form, paying close attention to both the date and the time in 24-hour format. The most common pitfall is an incorrect date, especially for incidents that occur around midnight. This is a major data error that invalidates all subsequent time-based performance calculations. Please double-check the date. For field number 2, highest level of care provided on site, you will select the skill level of the responding crew from the PHC form. The pearl here is that this data point relates directly to the structure component of the Donabedian model, as it defines the resources available to the patient in the field. For most Ministry of Health ambulances, this will be Level 3, Advanced Life Support, no doctor present. The pitfall to avoid is guessing this value. If the information is not clearly stated, you must refer to the MTR Data Dictionary or consult your supervisor. Part 2, On-Scene Assessment. Next, we document the initial clinical assessment. For fields 3 through 7, you will enter the first complete set of vital signs: pulse, blood pressure, respiratory rate, and SpO2, and the Glasgow Coma Scale score as documented on the PHC form. The PEARL for this section is critical. The GCS score you enter must be the pre-intubation score. A GCS recorded after a patient has been sedated and intubated does not reflect their true initial neurological state and is therefore invalid for this field. The pitfall to avoid is transcribing vital signs that were taken during transport instead of the initial on-scene vitals. The first set of vitals provides the most accurate baseline of the patient's condition immediately following the injury. Part 3, On-Scene Interventions. We now move to the interventions performed in the field. For fields 8 through 11, which cover airway, breathing, circulation, immobilization, and intubation, please note that these are multi-select fields. You must review the PHC form and check all boxes that apply to the interventions performed by the pre-hospital team. The pearl here is to understand that these fields document the process of care within the Donabedian model. Therefore, you must be thorough. For example, a patient may have received both a cervical collar and a spinal board for immobilization. Both must be selected. The pitfall to avoid is selecting none when an intervention was clearly performed. For instance, if the patient was intubated, you cannot also select none for airway management. These options are mutually exclusive. We will now focus on a particularly important field in this section. Field number 12, out-of-hospital intubation. This data point is critical as it documents the most advanced form of airway management performed in the pre-hospital setting. Your first step is to read the pre-hospital care or PHC form and determine if an advanced airway was placed. You will select either yes or no. If you select yes, a new set of options will appear, and you must specify the exact method used. Let's break these down, as the terminology is very specific. The first distinction is between a tube in the trachea and a supraglottic airway. A tube in the trachea refers specifically to an endotracheal tube, or ETT, which is considered the definitive standard for securing an airway. A supraglottic airway, on the other hand, refers to devices like an LMA or an iGel, which sit above the vocal cords. The second distinction is drug-assisted versus not drug-assisted. Drug-assisted means that the paramedics administered medications, such as sedatives or paralytics, to facilitate the placement of the airway. This is a key indicator of a higher level of care. The pearl, or best practice here, is to familiarize yourself with these terms. Knowing that tube in the trachea means ETT, and understanding what drug-assisted implies is crucial for accuracy. The most common pitfall is confusing these different airway types. If the PHC form is vague and simply says airway secured, do not guess. An incorrect selection here is a significant data error. The correct procedure is to ask a clinician on your team to review the report and clarify exactly which device was used before you make your selection. Part 4. Major trauma criteria and disposition. We will now address a set of fields that are fundamental to understanding the pre-hospital decision-making process. Fields 13, 14, and 15, which cover field triage. First, for field number 13, triage at scene. Your task is to record the triage color, typically red, critical, yellow, semi-critical, or green, non-critical, that was assigned to the patient by the ambulance crew in the field. This information should be taken from the pre-hospital care, or PHC form. Next, and most importantly, is field number 14, the major trauma triage criteria. This is not just a simple list. It is a formal checklist divided into 3 categories: physiological signs, anatomical injuries, and the mechanism of the injury. Your instruction is to meticulously review the entire PHC form and check every single box that applies to the patient. For example, if the patient's systolic blood pressure was below 90, you must check that box under physiological. If they had a suspected unstable pelvic fracture, you must check that box under anatomy. Finally, after completing the checklist, you will move to field number 15, major trauma triage status. This is an auto-calculated field. If you have checked even one box in the criteria list, the status is "positive." If no boxes apply, the status is negative. The pearl, or best practice for this section, is to treat the major trauma triage criteria as a formal audit tool. Its accuracy is absolutely vital for our quality improvement programs, as it helps us understand if our pre-hospital system is correctly identifying the most severely injured patients who require the highest level of care. The most common pitfall to avoid is guessing the triage color if it's not documented. If the color is missing from the PHC form, you must select unknown. An equally critical error is rushing through the criteria checklist and missing a positive finding. Take your time and be thorough, as the integrity of our system-level analysis depends on it. We will now cover the final fields in the out-of-hospital care section, fields 16 and 17, which document the disposition plan and trauma notification. These fields are crucial as they capture the planning and communication that occurs between the pre-hospital team and the receiving hospital. First, for field number 16, disposition, your task is to select the destination plan that was decided by the ambulance crew from the scene. This information will be documented on the pre-hospital care, or PHC form. Next, for field number 17, trauma notification, you will indicate whether the pre-hospital crew provided a pre-alert or advance notification to the receiving hospital's trauma team. you will select yes or no. If you select yes, you must then enter the exact date and time that this notification call was made. The pearl, or best practice for this section, is to understand that these fields measure system coordination. Pay close attention to the distinct terms trauma bypass and diversion to other hospital. Trauma bypass is a specific formal protocol to skip a nearer hospital and transport the patient directly to a designated trauma center. This is not the same as a general diversion to other hospital, which indicates redirection to a different facility for other reasons. Accurate entry here is vital for auditing these important system processes. The most common pitfall to avoid is incorrectly selecting trauma bypass when the patient was simply diverted to another hospital for non-trauma bypass reasons. This is a significant error that misrepresents the decision-making process. Additionally, a frequent and critical data omission is marking trauma notification as yes, but then forgetting to enter the mandatory timestamp. A yes without a time is incomplete data. Please ensure you are diligent with both of these fields. Part 5. Additional events. We will now conclude Section 3 by covering the final set of fields, numbers 18 through 22. These fields are designed to capture other critical events that may have occurred during the pre-hospital phase. Your instruction here is straightforward. For each event listed, which includes out-of-hospital cardiac arrest, out-of-hospital CPR, out-of-hospital FAST, entrapment, and analgesia, you will select the appropriate option, such as yes, no, or unknown, based on the information provided in the pre-hospital care or PHC form. Please note that some selections will require a follow-up. For instance, if you select yes for field number 19 and 21, out-of-hospital CPR or entrapment, it is mandatory that you also select the duration of that entrapment from the options provided. The pearl, or best practice for this final group of fields, is to understand that a no is just as important for data quality as a yes. For example, positively selecting no for out-of-hospital cardiac arrest provides valuable negative information. It confirms for researchers and auditors that the patient did not suffer this specific complication, which is crucial for accurate risk analysis. Therefore, do not skip these fields. The most common pitfall to avoid is leaving these fields blank. A blank field creates ambiguity in the database. It could mean the event did not happen, or it could mean the data was simply missed. To ensure the highest quality of data, you must make a positive selection for each item, whether it is yes, no, or unknown, based on what is documented in the source record. Let us summarize the key takeaways from this module. First, the pre-hospital care form is the sole source document for all data in Section 3. Second, data quality in this section is defined by the accuracy of timestamps and the completeness of clinical information, particularly the pre-intubation GCS. Third, the data you enter here directly informs the structure and process components of the Donabedian model. And finally, meticulous entry of this data is essential for evaluating our emergency response system and providing a fair baseline for in-hospital outcomes. This concludes the training for Section 3, Out-of-Hospital Care. You now understand how to accurately transcribe the critical events that occur before a patient even reaches our hospital doors. The data from this section tells the first chapter of the patient's story. By ensuring its accuracy and completeness, you provide the essential context needed to evaluate the entire continuum of care. This work contributes directly to the MTR's mission of improving trauma outcomes for all Malaysians. In our next module, we will follow the patient into the hospital as we begin Section 4, Emergency Trauma Care. Thank you.